Welcome to Dr. Michos, please. After that will be short coffee break. I hope you'll enjoy it too.
Okay. All right. Well, I apologize. We're running late here, and I'm right before coffee break, so hopefully you're all still awake. So I'm going to talk about coronary artery calcium scores, which have taken a little bigger play in the latest release of our cholesterol guidelines in November 2008 as a way that may help guide risk assessment when the decision to initiate statin therapy is uncertain, and this is for primary prevention. So in terms of why we should still assess risk and absolute risk, it's because that for our therapy, for our LDL reduction therapy, so this is at the bottom here, is for a given LDL reduction therapy, and on the y-axis here is the percent of major cardiovascular disease events prevented, that it actually matters what your absolute risk is, that you get the most absolute risk reduction with any therapy, statins, but also and other secondary prevention drugs like PCSK9 inhibitors. You get the most bang for your buck for those that are at higher absolute risk. And so by assessing absolute risk, it helps us guide our therapy decisions to identify individuals that will benefit the most from statin therapy and have the most net benefit and at the least sort of risk for harm. Now, this was in 2018, we had released a brand new cholesterol guidelines, which was an update from the previous ones from 2013. And so for risk assessment, they still kept the recommendation that we should start with the pooled cohort equation. This was first introduced in 2013, and you heard about these as race and sex specific pooled cohort equations. So in adults age 40 to 75 who don't have diabetes, they said if you were diabetic, you don't need to calculate the 10-year risk for deciding statin therapy. And LDL 70 to 189. So in this group, you start with the pooled cohort equation. There's online calculators. They have the same risk factors essentially in the Framingham risk score, but it predicts both total atherosclerotic disease, stroke, and in addition to coronary events. But they do acknowledge one of the big criticisms of the 2013 guidelines is that statins were recommended above 7.5% 10-year risk, and that there's a lot of problems with these calculators, and that may lead to overestimation or underestimation of risk treatment. So in the 2018 guidelines, so it emphasized you start with estimating 10-year risk, and it suggested you group people into 4 categories: those at low risk, less than 5% 10-year risk. In most cases, these individuals, with a few exceptions, a lifestyle alone is enough. And those that are high risk, greater than 20% 10-year risk, generally do benefit from statin therapy plus lifestyle in combination. But then the 2 groups in the middle, the intermediate risk, the 7.5% to 20%, and the borderline risk, 5 to 7.5%. They emphasize, and this concept was in the 2013 guidelines, but it's emphasized here, a clinician-patient risk discussion before starting statin therapy. And in addition, as I'll show you, there was certainly more emphasis on personalization of risk using additional factors. So again, the clinician-patient risk discussion is a class 1 recommendation that we should be having these conversations with our patients about their 10-year risk, their risk factors. There was a whole table about risk-enhancing factors that modify risk, and this does include things like ApoB and kidney disease, CRP levels. There's even women-specific factors such as preeclampsia and early menopause. So there was a whole table of risk-enhancing factors that you can consider to help modify this risk. And you can talk to them about the benefits of lifestyle plus statins, the potential for adverse effects, understand their patient preferences, and come up with a shared decision-making plan. So, I'm going to move to coronary calcium, of course, which is the subject of this talk. But why that we need to maybe do some more personalization beyond just calculating the pooled risk equation is that it became quite clear after it was released in 2013 that at least in populations where there's high socioeconomic status, these calculations tend to overestimate risk. So this is data from the MESA study. This is just men here, but it's similar for women. And this is the other calculators, but this is the pooled cohort equation. And if you look at observed risk versus predicted risk, there's systematically predictive risk is much higher than observed risk. So it overestimates risk. It's predicting risk higher than observed risk. So if you were to go just by the 7.5% threshold, there is a large subset of individuals who would not be really expected to benefit from statin therapy, that their risk is lower than the calculator may say, and that may lead to over-treatment. But there is, so this is high overestimation of risk in high SCS populations, engaged patients, but there's also the problem for underestimation of risk. There's a lot of factors that are not in the risk calculator, such as HIV and inflammatory disease, and in these cases, actually the risk calculator may underestimate risk. It's reasonably calibrated for the group here in the middle. So recognizing all this controversy that came out in 2013, the latest release does give a 2A indication that you can help, in addition to calculating the risk, consider additional risk-enhancing factors, and I mentioned those, it's a separate table. But then the subject of this talk is now was given a 2A indication that after you estimate the risk by the risk calculator, and after you consider all those risk-enhancing factors in that table, if it's still unclear, what this individual's absolute risk is and the net benefit they would be expected to gain from statin therapy, you could then consider a coronary artery calcium score to help guide treatment decisions, either withholding or postponing initiating statin therapy. So again, it doesn't say everybody needs to be screened with calcium scoring, but it does say that for a 2A indication, it's reasonable in this subset where decisions are uncertain. I think what this is really helpful is that these risk equations, like the pooled cohort equations, is largely driven by chronological age. But chronological age is really not the same as vascular age. And a man or a woman really is only as old as their arteries. And so having a better marker of actually of biological aging as opposed to your calendar age. And that's where coronary artery calcium seems to be really helpful here. It's obtained by a non-contrast CT. There's a very small amount of radiation, as we'll talk about. It's less than 1 millisievert, it's less than what a bilateral mammogram is. And we're not getting this every year like women who get mammograms do. And because as plaque is building up in the arteries, a certain percentage of it can become calcified. And because calcium shows up bright white on x-rays, you can see it in the arteries without any dye. And prior histopathology studies have shown that it's pretty well correlated, that the amount of calcium correlates with total atherosclerosis burden. So certainly it's not picking up the non-calcified plaque, but in generally the patients that have more non-calcified plaque, certainly if they're over a certain age, have more calcified plaque. So it's a reasonably good surrogate marker for total atherosclerosis burden. And, it's been seen in multiple cohorts over and over again. There's been numerous studies that show it's superior in predicting risk than risk scores alone. And that's because it's really measuring the disease. It's actually measuring atherosclerosis directly by imaging, as opposed to risk scores that are looking at a biomarker at a single point in time, your CRP on one day, or even your blood pressure, your lipids. This is trying to estimate risk, where this is actually measuring the disease itself. So it's been compared to numerous other biomarkers and imaging markers. And the reason why coronary calcium got the bigger play in the guidelines with the 2A indication is that this is data from MESA, the multi-ethic study of atherosclerosis population, community study cohort, really showed that coronary artery calcium was the only one that really changed the C statistic and the net reclassification compared to IMT and endothelial function, CRP, family history, all these things. It's the only one that really helped predict risk. And in the multi-ethnic study of atherosclerosis MESA, as I alluded to, followed out for 10 years, a coronary artery calcium score really splayed out risk very nicely. So here's the race data, the whites, Chinese, blacks, Hispanics, and MESA. And this red line is the 7.5% risk just by the pooled cohort equation. And over 10 years, those with high calcium scores, really anything above 1, but particularly if you're above 100 or 300, they were at much higher risk of having an event than predicted by the pooled cohort equation. On the other hand, this bottom line here is a score of 0. So a calcium score of 0 isn't associated with no risk, but it's about a 0.1% per year risk. So it's certainly well below the established sort of treatment threshold, and it's at a level of low risk that patients and their providers may feel more comfortable about deferring or withholding statin therapy. So that was the race data. This is from the same study in MESA. This is men and women and men, just to show that it also works in splaying out risk in both men and women. And you can see there's really quite separation of risk depending on what your calcium score is. And this was just a meta-analysis looking at a bunch of cohorts for women who are low risk, showing that calcium predicted risk much better than risk factors. And even in age groups, so MESA enrolled people age 45 to 84, and then across the 4 age groups, we see even on all these different age groups, it predicted risk. So it predicted risk equally nicely across race, across gender, across age. It's a very powerful marker of risk. So getting back to age, really coronary calcium predicts actually much better than your chronological age. If you, now again, your calcium score in the population does become more prevalent as people get older, because atherosclerosis is more prevalent when you get older. But if you happen to make it to older age and have a 0 calcium score, your risk of a coronary event is much, much lower than a young individual who has a high calcium score. So it's the calcium score here in the red is scores over 100 that much more predict your risk than your age, your chronological age. Now, same thing we see with risk factors. So a lot of us sometimes don't even bother with the pooled cohort equations. You just kind of count up risk factors in your head, which isn't quite a very good way of doing things. But even in people with multiple risk factors, if their calcium score is 0 here in the yellow, they're at also pretty low risk of an event. Compared to people who with no apparent risk factors, if they had a high calcium score, they have a very high risk of event. So again, calcium scores predict better than age, it predicts better than lipid values, it predicts better than total risk factors. So while previously some of the guidelines and clinical practice had been using coronary calcium to sort of up titrate risk, to identify people who we should treat more aggressively, actually what I think the most single beneficial use of coronary calcium is its ability to sort of de-risk or downgrade risk, so that maybe we can spare or delay some people some statin therapy that they might not benefit from as much. So it has a very powerful negative predictive value. And again, compared to multiple other biomarkers, either having normal levels or absence of all these different things, again, IMT and carotid plaque, ABI, CRP, family history, there's a whole bunch of things they compared it to. It really was only coronary calcium that really changed the post-test probability compared to the pre-test probability in down titrating risk. And this is why we may feel more comfortable in if the patient's not, as part of the discussion, not interested in starting statin therapy because their risk is pretty low. If this is looking from 7 registries, and individuals with a coronary calcium score have about a 0.1% risk of a major adverse event per year. So sort of well below the 7.5% 10-year threshold. And, if statins were to confer, as they do pretty consistently, a 20% relative risk reduction, if your absolute risk is so low, even if you had a 20% reduction in the absolute risk, you're going to reduce 0.1% to even lower. So people may choose, as part of the discussion, to withhold statin therapy. So again, getting back to that absolute risk content, if you had a 0 calcium score, your absolute risk is so low, you would have to treat a lot of individuals, more than 500, to prevent one event over 5 years. Or if you had plaque in your arteries, your event rate's high enough that you don't have to treat many people to prevent one vascular event. Now, we're talking about cardiovascular events, but I do think it's interesting that coronary calcium actually does predict non-CVD events too, such as pneumonia, COPD, DVT, dementia. Now, this is not causal, obviously, this is outside of the heart arteries, but it may be that coronary calcium is just a good marker of someone who's not aging well and is at high risk for a lot of different comorbidities. So this was a review article I wrote, really why we think that CAC is so powerful. Again, it's measuring atherosclerosis that's built up over decades, and so it's a really good integrator of risk. Not only is it an integrator of the traditional risk factors we can measure and genetics and novel risk factors, it's integrating risk factors we haven't even thought to measure yet. And it can help decide whether we want to upgrade risk and consider a statin or downgrade risk. So this slide, sorry, it's hard to see. This was modeling from Mesa earlier, before the guidelines came out in 2015, suggesting that the group that would benefit from the CAC the most is the 5 to 20% risk, which is in the middle. So in individuals who have a 10-year risk less than 5%, whether their calcium score is positive or negative, their risk is still pretty low, less than 5% 10-year risk. So your risk is a little higher if your calcium score is positive, but your overall risk is pretty low. So in most cases, we're not recommending calcium scanning in this really low risk group. On the other hand, this is over here on the right. These are people with more than 20% 10-year risk. And whether your calcium score is positive or not, your 10-year risk is still above 7.5%. It is graded a little bit by the presence of CAC, but you still have a higher risk. So we're generally not screening these people. But it's the ones in the middle, particularly if you're above 7.5%. But even in this borderline group, 5 to 7.5%, it would shift you above or below sort of the 7.5% threshold. And this is why in this review article by Phil Greenland and Jack, this was actually came out before the cholesterol guidelines, but this is kind of what the guidelines said too. You know, if you have a score, 10-year score by the full cohort equation less than 5, you don't really need to use CAC. CAC is really not that effective. We generally don't recommend statins in this group. If your risk score is above 20, we recommend treating you. You're at high absolute risk, and we recommend statins, and so we don't really recommend a coronary calcium score because statins are recommended. And then it's this middle group where calcium score can up classify or down classify to help guide the discussion. So this is what specifically the guidelines had said in this group of 7.5 to 19.9, and they said selectively, not everybody in this group, but there may be some if they have a family history or something, and 5 to 7.5%. If after talking to the patient, if their risk is uncertain, you consider a calcium score. But the guidelines, I think, did point out that there's some groups where you may feel less comfortable with a coronary calcium score of 0. Particularly ongoing cigarette smokers, patients with diabetes, those with a really strong family history. You may feel a little bit less comfortable deferring therapy with a coronary calcium score of 0. And again, a coronary calcium score 0, again, this isn't no risk, it's lower risk, and clinical judgment about risk should still prevail. And the guidelines said if the calcium score is greater than 100 or above the 75th percentile, they recommended a statin. But they even generally recommended a statin if the calcium score was 1 to 99, more modest. So that's for statin therapy in the cholesterol guidelines. There is some interesting data modeled from observational data about using calcium scores for aspirin decisions. And this was data from Mesa. You know, we're not really using aspirin much anymore in primary prevention, but the one group who might benefit is people with a lot of plaque in their arteries. Certainly if your calcium score is 0, you'd have to treat, even if aspirin reduced your risk by 9%, you'd have to treat, you know, like 2,000 people if your calcium score was 0, and certainly put you plenty of risk for harm of bleeding, this red line. But if your calcium score is high, the event rates are high enough that it may favor aspirin treatment. So this is probably one of the few groups I use aspirin in, is those with high calcium scores if their bleeding risk is low. And the Society for computed tomography, that was similar to our cholesterol guidelines, but they did put an aspirin note in here too. they said in their statements that if your calcium score was 0, we don't really recommend statins, and this excludes genetic severe hypercholesterolemia. We still treat, FH, not based on calcium scores. That a moderate intensity statin, moderate to high, for those 199. If your score is above 100, considered a moderate to high intensity statin plus aspirin. And if you're certainly above 300, a high intensity statin plus aspirin. And that's generally how I practice. So, like any test, there's some limitations. There is a very modest amount of radiation. I guess I mentioned it's about the same as a bilateral mammogram, but it's actually lower than the background radiation of us just walking around over a year in the United States. There is some risk of incidental findings of pulmonary nodules. This can be minimized if you sort of reduce the scanning fields, so you only focus really on the heart and not get too much of the lung fields. Unfortunately, the Fleshner Society guidelines, the last version, has become a little bit more lenient, where if you're low risk, any solid nodules below 6 millimeters don't need follow-up. But if you do find some of these above that, it might need some workup, and that's the downside. It's important to know what to do with a calcium score. These are asymptomatic people. So a calcium score should not trigger referral to angiography. It really even shouldn't trigger to stress testing, although there was some guidelines for nuclear testing with those with really high calcium scores. But in asymptomatic people, we treat for prevention. It shouldn't trigger downstream testing. And the question is that we really shouldn't be, if we've made the decision to put someone on a statin, rescanning is usually not indicated. Calcium progression certainly is predictive of risk, but what happens with statin therapy, it actually can make your calcium score goes up because the statin shrinks the lipid part, the modifiable part, makes the plaques more dense and actually probably more stable. So statins reduce ASCV risk, but it makes the calcium score go up. So it's really not a good marker of people on therapy. The only time I rescan people is when they were 0 and we decided to withhold a statin, and in 3 to 5 years, the warranty period, I'll screen again. But once I made a decision to put some on statins, we don't follow serial calcium scores. That doesn't mean the statin's not working. And the other big criticism is people say, well, there's never been a randomized clinical trial of a calcium-guided therapy versus a risk factor-guided therapy. But I would argue there's never been a randomized clinical trial of the pooled cohort equation either. And there's very compelling observational data. And certainly in the St. Francis Heart study, we know that people with high calcium scores benefited from statin therapy. And there actually is a trial going on in the Netherlands looking at coronary calcium versus risk factor screening that might be interesting. But some of the critics bring that up. So who are the top 7 indications of who I use coronary calcium testing for? So again, the intermediate risk patient, 5 to 20% when risk is uncertain. Maybe a lower risk patient with diabetes, someone with a strong family history. I see a lot of statin reluctant patients in my practice. And I think this can be really helpful to understand their absolute risk. If their score turned out to be 0, we talk about how their estimated risk is now fairly low over the next 5 to 10 years, and maybe we can just do lifestyle. They're often thrilled because they don't want to take the statin. On the other hand, if their calcium score comes out really high, I've had a lot of converters that change their mind. I show them their scan, I show them their plaque and their arteries, and once they see all that plaque in their arteries, a large number of them who didn't want to take a statin have their mind change. And there's been data showing that more compliance with preventive therapy has been improved with knowledge of their calcium score. And patients who are actually statin intolerant, this helps me too also, like how aggressive, we try all different statins and different regimens and everyday dosing, and we go through all these hoops trying to get them on statins for a primary prevention. And so it helps me guide how aggressive I need to be really trying to get them on their statin. Certainly if they have a 0 calcium score, they might not need their statin. But actually in secondary and high-risk primary prevention, if they have a really, really high calcium score, that's when I start considering sort of non-statin therapy to bring their LDL down if they can't tolerate the statin. So there's decisions also for non-statin therapy. The event rates in patients with high calcium scores actually are similar to secondary prevention patients with a history of prior MI. So in very high calcium scores, I kind of almost treat them like secondary prevention, and we'll try to get their LDL less than 70. We talked about decisions for aspirin. And while calcium scores are designed for the asymptomatic individuals, there is some school of thought about using calcium scores as a gatekeeper for low-risk chest pain, as whether you would go on for a CTA or a nuclear stress test, that if they're having sort of atypical chest pain and you don't really have a strong suspicion that this is due to ischemic heart disease, a zero calcium score can be reassuring. Certainly anybody with high suspicion of ischemia, we don't use it for that purpose. But again, as I mentioned, motivation, patients certainly become, at least in studies, a little bit more compliant with preventive therapy once they know their disease burden. So, in summary, I like this quote. We all want to be superior doctors and prevent disease. That's why we're here at this prevention conference. We certainly don't want to be inferior doctors and wait till the disease is full blown, because as you know, the first manifestation of cardiovascular disease can be sudden cardiac death. So if we can't be superior doctors, let's at least be mediocre doctors and try to treat the disease before it becomes clinically evident. And that's where subclinical atherosclerosis comes in. And so I thank you for your attention.